interest in sexual dysfunction in cardiac disease, and will address this topic particularly with a view to hypertension. Thanks very much.
Thank you very much, and thank you for asking me. I got the reputation of being the sex cardiologist on the radio in Los Angeles. Sexual dysfunction in hypertension, I'm going to tackle really from two perspectives. First is to alert you to the fact that erectile dysfunction is an important marker of coronary artery disease, which is asymptomatic. And the second, which is probably what you all know, is that a lot of the drugs we use could possibly cause erectile dysfunction, and the way around that particular problem. I think the first thing to say about the talk is we're really talking about sex. It's let's talk about sex. Let's ask the question. And let's ask the question before the treatment is initiated, because approximately 60% of hypertensives will have erectile dysfunction before you start the treatment. So blaming the drugs is not necessarily the answer to the question. Why are we interested? Why are we preoccupied with sex, if you like, with regard to normal daily life? Well, the World Health Organization summed it up, and it's often important to go back in time, this is 1970, to what some people have said at that moment in time, which is still relevant to us today. With regard to sexual health, it's the capacity to enjoy and control sexual reproductive behavior in accordance with your ethic. Homosexuals, heterosexuals, racial groups, doesn't matter. You have a right. You have a right to be free from any shame, guilt or false beliefs. Your religion often interferes with that right, but you have that right. And then factor 3 here is freedom from organic disorders, hypertension in this particular case, coronary artery disease, and various other deficiencies which may interfere with sexual and reproductive function. Now, those are the rights of the individual, and rights come with responsibilities, and it's the responsibility of the healthcare professional to fulfill those rights. People think as you get older, you get too old for it. So in women there are problems, and I'm not an expert on female sexual dysfunction, and I do recognise that it is a complex issue with many factors involved. But the commonest problem is the lubrication issue, which develops after the menopause and which can be exacerbated by the diuretics. In fact, it's regular sex which keeps the postmenopausal female lubricated, and it's regular sex she's not getting if her partner has erectile dysfunction. Erectile dysfunction is the commonest problem we're dealing with. I suppose one could say sexual dysfunction in women is complex, and in men it's pretty obvious. And it leads to anxiety and lack of self-esteem, depression, and so forth. 20% of all relationships in the UK break down because of erectile dysfunction alone. Now, that's quite a staggering figure. So in terms of interference with lifestyle and so forth, erectile dysfunction is very common and a very treatable problem. There are two scenarios, I think, for men. A man has ED, but we don't ask. I suppose now all members of the audience routinely ask, if you have a hypertensive who comes in for the first time, how many of you do ask about erectile dysfunction? Yet 60% are sitting there in front of you with a degree of erectile dysfunction. So asking is very important. Then the man has got ED, but our therapy results in ED. He's not got it, but we give it to him. Now, there's been a very recent paper published from Holland about cardiologists and how bad they are at talking about sex. Only 2% sent their patients for specialist advice. 45% of the cardiologists didn't offer advice because the patients didn't ask for advice. Yet the common theme of all the publications is the patients want their healthcare professional to raise the subject. It is the patient sitting there waiting for you all to bring up the subject. And it's very important that we do so for obvious reasons. Now, defining erectile dysfunction is very straightforward. The inability to get an erection good enough for penetrative sexual intercourse. All men misfire once or twice, that's quite normal. But this is a consistent problem over 2 to 3 months. Erectile dysfunction, in terms of how men see it in terms of penetrative sexual intercourse, isn't always the issue. Men in my clinic certainly have asked for their erectile dysfunction to be treated because they want their morning erections and their nocturnal erections back again. Why? Because they want to feel a man again. They don't want sex, they just want to feel a man again. So there are issues beyond penetrative sexual intercourse which are important. And the thing I've worked on since the 1990s is the link between erectile dysfunction and the heart. And we came up with this explanation, if you like, in 2003, which we published in Heart. And as you can see in this, ED is the common denominator. Erectile dysfunction equals endothelial dysfunction. And I would think in the last presentation, a method of evaluating endothelial dysfunction at the start in those women would be very important. Coronary heart disease and erectile dysfunction share the same risk factors. And the common denominator is endothelial dysfunction, which is where the drugs particularly work, PDE5 inhibitors. We've now moved on a bit to accepting this link. And this I put up because it boosts my ego enormously. And you can see GJC there is the Graham-Jackson link chain. And this was proposed at the World Congress last year. And is the link between the two. You've got the hypertension, cardiovascular disease, and ED, endothelial dysfunction. And then you've got antihypertensive therapy. And the risk along the bottom is the risk that we run into in terms of inducing ED against our benefit of effectively treating hypertension. And the link between cardiovascular disease and ED is now firmly established. So ED is a marker of cardiovascular disease even when the patient has no cardiovascular symptoms. And in the Princeton guidelines, we've got a series of guidelines on the subject. The first was in Princeton in New Jersey in 1999, and there are 3 sets of guidelines, of which I've been involved in all 3. And this was the conclusion of the Princeton second. And see, it's 2006, so we're really looking backwards to information we've had for quite a long time. And the conclusion of that was the recognition of ED as a warning sign of vascular disease has led to the concept that a man with ED and no cardiac symptoms, this is very important, is a cardiac or vascular patient until proved otherwise. So we need to be on alert with regard to the person with ED. And we have produced 2 consensus statements in the past couple of years. This is the British consensus statement, which I chaired, and it involved representatives from the field of sexual medicine, cardiology, and the International Society of Sexual Medicine as well, and a representative from several other societies. And we came up with several recommendations at that point. And then the Princeton third consensus, very, very important consensus to read, was published only last year with regard to grouping together the recommendations. The British one, I would like to say, actually, is the most practical. And so I'll just concentrate on 1 or 2 points, which I think are relevant to the subject. That is, a significant proportion of men with ED exhibit early signs of coronary disease. And this group may develop more severe coronary disease than men without ED. So if you're sitting there and you're treating somebody with hypertension, and one of the 2 men with no symptoms has ED, that person is at markedly increased risk of a cardiac event compared to the hypertensive with normal erections. And if you apply that rule to diabetics, type 2 diabetics, who are asymptomatic, who have normal erections, their chance of a cardiac event in the next 5 years is 4%. Their chances of coronary event, and if you have ED, is 35%. So there is quite a major step up in patients who are asymptomatic who have ED. And this is one of the most startling studies of all. This is the Inman study, and they're looking at a follow-up study of 10 years with men baseline ED and no baseline ED. And if you focus on the younger age group, what you see across the top there is that men aged 40 to 49 have a 50-fold increase in a cardiovascular event. Now that is greater than any other risk factor on the planet. You know, you can measure the chocolate, the homocysteine, the serum rhubarb. All you have to do is ask the question. And health economists will be delighted. It's cheap. It's going to be free. Is your willy working? If your willy is not working, you are at substantially increased risk, independent of lipids, blood pressure, diabetic status. As you can see, that risk persists but disappears because of the impact of age. So ED is a predictive of coronary events in asymptomatic men. More disturbingly, a study from Western Australia looking at exactly the same kind of subject, but retrospectively, that other study was prospective, looking at ED and no cardiovascular disease prior to ED versus the general population. And what they found in this particular study was this: a 7-fold increase in men less than 40. And that 7-fold increase actually translates into 20-year-olds. So I don't know about you, but when a person comes in to my surgery with ED and he's 24, I immediately think it's psychological. But we have to think also it could well have organic implications because there's a 7-fold increased chance. The second recommendation which we made was concerning the time interval. The link between ED and a cardiovascular event is between 2 and 5 years. And this was studied in a British study in general practice, where 207 men attended cardiac rehab, and there were 165 age-matched controls. Look at the incidence of ED in men with cardiovascular disease. It's very high. And across the board, whether you do a study in Los Angeles, in England, or in Asia, the incidence is around about 70%. These are the controls. Look at what the incidence of ED in the so-called normal controls. These are supposed to be men without the problem. Why did they have the problem? Because somebody asked. Somebody asked as part of the protocol. 37% had the problem. They had not yet volunteered, and they were at substantial increased risk. And the authors concluded there were missed opportunities to assess the risk, and that men with ED should be targeted for cardiovascular risk reduction aggressively. In actual fact, men with ED in this age group, particularly the younger age group, are now classed by us as cardiovascular equivalents, rather similar to type 2 diabetics. The theory is the artery size hypothesis. You see on this side here a penile artery 1 to 2 millimeters with endothelial dysfunction, giving you ED. The same amount of problem in the coronary arteries, 3 to 4 millimeters, gives you no symptoms. It will also give you a normal exercise test, because an exercise test will only become abnormal if there is a narrowing greater than 50 to 70%. Yet that's the one that kills you. That's the plaque that causes sudden death. That's the plaque that causes acute coronary admissions. 50% of all people who drop dead have no warning signs, no cardiac history, and that's the reason that ruptures. So could ED predict acute coronary syndromes, and furthermore, could it predict death based on this hypothesis? 300 people admitted to coronary care unit in Milan, had angiography, typical age group, ED prevalence before the acute event, 49%. ED before the symptoms developed, 99 was 67%, with an average gap of 3 years. Now, this is called the window of opportunity, the window to interfere, hopefully to reduce the acute coronary events. But also, I'm afraid to say, ED is linked to death. In other words, the artery size hypothesis holds up here as well. In this particular study, there were no cardiac symptoms at all, and they were 1,600 men. D is diabetes. It goes up as ED increases. A 26% excess all-cause mortality driven by a 43% cardiovascular mortality. Now, these people, as I said, had no cardiac symptoms. So it's a predictor of acute coronary care. It's a predictor of death. And this is a study that I've just had accepted for publication, where I looked at 65 patients referred to me with ED and no cardiac symptoms, and I was interested in finding out whether these people had silent coronary disease and how to predict it with an exercise test or CT coronary angiography. And as you can see, 12 were hypertensive, incidentally very well treated. The results of the study are, in fact, quite disturbing. The exercise test was normal in 61. The angiograph was normal in 5. So with regard to an exercise ECG, it is useless in identifying a coronary artery disease that's silent in this population. And alarmingly, a significant number of people at CT angiography have coronary artery disease they don't know about. And they all need intervention with aggressive risk factor reduction. This is in patients with known cardiac disease, the ED, a baseline, and then 2 years, which is a short follow-up. But as you can see, those with known coronary artery disease have increased cardiovascular death, MI, and the composite, including heart failure. So in those with known and in those with unknown coronary disease, cardiovascular disease, ED is a powerful predictor. So be aware that ED is important, it is frequent, it's at least 60% of hypertensives, 70% of type 2 diabetics, 77% of type 2 diabetics with hypertension. The prevalence of ED in hypertensives, this is a small study, 104 men with hypertension, 68% had ED. The International Index of Erectile Function is a validated tool for predicting severity of ED. And as you can see, 45% had severe ED. The scores on the IEF were very low. And in 10% of the general population, they compare to that. In a huge study from Francois Giuliano, 7,600 men, hypertension alone 67%, diabetes 71, 77. Yet, bottom line, how many were treated? 65% untreated. It's very, very sad when you remember the relationships that break down and the treatment that we have that's available. Are men with ED more likely to have hypertension? Urologists. I'm not talking to urologists, but if I was, do you measure the blood pressure? Well, they do at Guy's and St Thomas's now. They didn't used to, but they do now. Men with ED, 41% had hypertension they didn't know about, because nobody ever measured their blood pressure. And as you can see, 42% had in a huge database from Alan Seftel. Men with hypertension are more likely to have ED, and men with ED are more likely to be hypertensive. We need the urologist to measure the blood pressure at every clinic visit. Guys and stomatologists do the blood pressure, lipids, and glucose, thankfully. So we say ED is the barometer of men's health, the deadly quartet. And here we have 4 retired cardiologists discussing their willies. With regard to treatment, in the trial comparing valsartan with carvedilol, and including placebo, there was quite a difference in erectile dysfunction. As you can see, carvedilol is the same patients. It's a crossover study, same blood pressure control, 0.9% with valsartan. What's interesting is when you look at the monthly sexual activity, we compare it with the placebo, it actually goes up with valsartan. So they have more sex when they're on valsartan compared to placebo. And that's particularly interesting because angiotensin II does impact upon PD5. So angiotensin II will increase PD5. And you know this cyclic GMP, smooth muscle relaxation, and then you get a hypotension, and that also you get erectile function. It's interesting, if you look at this whole algorithm here, you can see the potential impact of PD5 inhibitors combined with that angiotensin II antagonist in the treatment of heart failure. Currently, $20 million are being spent looking at tadalafil in heart failure following this algorithm. And this, when you increase angiotensin II, you increase PD5, you decrease smooth muscle relaxation. So if you give them a thiazide, they'll get erectile dysfunction more than anything else. If you knock out the two, you will get erectile function and antihypertension. And it follows that combining an ARB with a PD5 inhibitor could be dynamite in the treatment of hypertension. Because not only will it work, but your erections will increase, so it'll actually be sexually friendly as well as hypertension friendly. In a trial of losartan in hypertension, in 82 men, the prevalence of ED fell from 75% to 12%, so it appears to be a class action. And if you looked at the effect of valsartan on sexual function in hypertensive men, you found that it increased erectile function, orgasm, desire, overall satisfaction. Beneficial. So I would submit that in the younger patient, and certainly in the patient below 60, angiotensin II antagonists are the drugs of first choice. And that can be said also for irbesartan, where you can see at 6 months on the left-hand side, the erectile dysfunction improves. It's important also, listening to the previous presentation, bariatric surgery improves erectile function. Losing weight and intensive training improves erectile function significantly, as well as lowering blood pressure. 20% of one group of patients who receive the same kind of intensive therapy actually restore their erectile function without drug therapy. So lifestyle advice is also important. We know that the drugs that we use to treat hypertension, in this old study, which didn't have a validated questionnaire, and you can see that only doxazosin was equivalent to placebo. But the other drugs were, in my view, acceptable. It's just thiazides that are the enemy of the erection. So, in conclusion, bringing together that information, it's very important to start asking. If you don't ask, you'll not get any answers. I ask every single hypertensive, every single heart failure patient about their sex lives. That's why I got this name of being a sex cardiologist. I warn everybody about the sexual side effects that can occur. And if they do occur, they're to speak to me or make an earlier appointment so we can change the therapy. I don't want to lose patients because I've given them erectile dysfunction. I don't want the West Indian with hypertension in Brixton to disappear because I've ruined his sex life. I want him back again so I can use different drugs or advise on his sex life. It's very important with maintaining adherence to therapy. Or what's it, concordance? They used to concordance. Advice on lifestyle is very important. Choosing the drugs very carefully. And please, the main message is don't stop there. screen the patients for cardiovascular disease. I'm sorry we don't have the information on women that we should have, but we don't have the information there. But I still believe they should be screened as enthusiastically as men for cardiovascular risk factors. The evidence is stronger for men, but clearly across the population, ED is a marker of increased risk, which we can modify, and we can treat the erectile penis. It's not just about that. It's about the cardiovascular disease that is lurking there, that we can use the erections to prevent a subsequent cardiac event, including death. Thank you.
Thank you very much. I'm sure this talk will have resulted in quite a few questions from the audience. From the front row here.
Thanks very much.
Oh, hang on, the microphone's just on its way.
I was wondering if there's any information on whether statins improve ED through increasing bioavailability.
It's a very important question. The only evidence we've got of improvement is with the atorvastatin, and that's with very small number trials. And there's an improvement in endothelial dysfunction and an improvement in erectile function. We have information that simvastatin can cause erectile dysfunction. It may be because of a lot of comorbidities and purely the effect of that, or it could be because it's the most lipophilic, it's having a central action. And if you take people who get erectile dysfunction on simvastatin, they may well be depressed and have concentration problems as well. And you switch them to pravastatin, which is water-soluble, the erectile function improves.
Question there?
Hi, I'm over here.
Sorry.
It's not so long since this society discussed differences between thiazide diuretics and thiazide-like diuretics, which we're keen on using. I use a lot of those in my patients because it's a good first line after stroke. So I'm worried about what you said. Is indapamide all right? And dose is clearly important.
Yep.
And so indapamide slow release is a lower dose, which seems to be quite as good. And the other thing is a slight discrepancy, because if you treat somebody's blood pressure well, you would hope their endothelial dysfunction would improve. So, over time, do they, maybe there's an acute effect of the drug, and then over time, if you've managed their blood pressure well and the risk factors well, maybe they improve.
Right. Indapamide slow release is the preferred diuretic, because it is, of all the diuretics, the one that is the least likely to cause erectile dysfunction, but it still causes erectile dysfunction. And so you still have to be alert to the possibility. With regard to endothelial dysfunction, it's a question of degree, I'm sure, here, and a question of time. I would hope that as you use drugs which affect endothelial dysfunction, like the statins that we've discussed already, that over time it would improve erectile function. But that data is not available, largely because the people who did the statin trials didn't ask. So if you speak to Peter Seaver and you speak to Neil Poulter, they didn't ask the question. And I'm sure at the present time they regret that, because they had the answer in front of them. They had the answer to your trials right in front of them there and didn't ask the question, which is a shame, but in those days it wasn't routine.
Okay, we have two final questions, Philip and then Professor MacDonald.
You've used the dichotomized variable of the ability to have penetrative sex versus not, but if you use something like penile turgidity, absence of morning erections or nocturnal erections as another marker, would you end up with the same sort of result?
Thank you, that's a good question. Using nocturnal erections and early morning erections, that's a marker of an organic cause of erectile dysfunction. And the person who comes in complaining of erectile dysfunction, who has normal nocturnal erections, that is much more likely to be a psychological issue. I'm just sort of putting that in the question. With regard to your specific question, if the nocturnal erections improve, and we have a thing called Rigiscan, and if the nocturnal erections improve, you get the same kind of information with regard to improvement that you get with cardiac erectile dysfunction in general at the time of sex.
Last question from Tom MacDonald.
Graham, hi. We studied tadalafil quite a long time ago.
Yeah.
I think just before it was licensed, actually, and we showed it was really quite a good antihypertensive drug. It lowers blood pressure in hypertensives, but it doesn't do it in normals. And I thought that Lilly should license this as an antihypertensive drug, but they seem very resistant to do so. Do you think there's any chance of us getting a license as an antihypertensive drug for these PDE5 inhibitors?
Tom, it's very logical. Oliver did the same with sildenafil, 50 milligrams 3 times a day, showing that it reduced the blood pressure as a monotherapy by 15/10. The PDE5 inhibitors seem to lower the pressure more when they're added on, when the pressure is more difficult to treat. But they're clearly antihypertensives. I agree entirely. Tadalafil would make a wonderful antihypertensive. Because as I said, if you combine that with an ARB, you have 2 antihypertensives, both of which improve your sex life. I mean, offer a person that option and say to them, I can give you a thiazide which may ruin your sex life. Which would you prefer? I mean, it's obvious. I wrote to Lilly, and Lilly were not interested. And I wrote to Novartis, suggesting that they produced a combination product with Lilly to trial. In other words, valsartan and tadalafil. Not interested. The difficulty I had explained to me was that they were making so much money with a license for erectile dysfunction, they didn't want to cloud the issue. But, I mean, as a society, I think if you were to lean on people to look at PDE5 inhibitors, they have fantastic cardiovascular potential. Heart failure, pulmonary hypertension, Raynaud's phenomenon, hypertension itself, who knows, preeclampsia.
Thank you very much. I'm sure that presentation's given us food for thought. Thank you.